topic for discussion today is Cushing syndrome. As we all know, adrenal gland has a very important role, and the hormones secreted by adrenal gland, that are the corticosteroids, mineralocorticoids, are very important for the normal homeostasis of the body. So Cushing syndrome is where there will be cortical excess, either pituitary dependent or non-pituitary dependent cortical excess. So Cushing syndrome was first described by Harvey Cushing, and hence the name as the Cushing syndrome. The common etiology is usually it can be iatrogenic, or it can be because of any endogenous or exogenous excessive cortisol secretion. So this endogenous cortisol secretion can be because of any adrenal adenoma or any tumor of the adrenal gland, or it can be any normal adrenal hyperplasia or ectopic adrenocorticotrophic hormone syndrome, or a prolonged medical therapy with the exogenous corticosteroids. So what is this? How is this cortisol actually secreted? What is the mechanism? So from the hypothalamus, there is a hormone that is released called as corticotrophic releasing hormone. This corticotrophic releasing hormone will have a stimulating effect on the anterior pituitary, where this anterior pituitary will release a hormone called as adrenocorticotrophic hormone. This adrenocorticotrophic hormone is a stimulating hormone again on the adrenal cortex, where it will release, after stimulation with ACTH, it will release cortisols. After the body, the blood levels of cortisol are to the required level, then it sends a negative feedback mechanism. Through a negative feedback mechanism, it sends a message to both hypothalamus and anterior pituitary, where the corticotrophic releasing hormone and ACTH will be stopped. That is how cortisol is usually maintained in the body. Whenever there is any endogenously, if there is any anterior pituitary adenoma or any excessive secretion of ACTH hormone, then there will be constant secretion of this stimulation of the adrenal cortex, and hence there will be excessive secretion of the cortisol. And sometimes what happens, there will not be any negative feedback mechanism, where the cortisol levels, though it is increased within the blood, it will not send any negative feedback to the hypothalamus or to the anterior pituitary, and thus there will be elevated cortisol levels within the body. This increased cortisol levels in the body, or hypoadrenocorticism, is nothing but Cushing syndrome. What is the actual function of this cortisol? Cortisol has various functions in the body, because it goes and affects every cell within the body. Hence, it affects our multisystemic. Okay, it has a generalized effect on the body. What are the various functions? It has blood pressure. It has effect on blood pressure. It has effect on bone formation and also on the inhibition. So on bone regulation mechanism, it has an anti-inflammatory effect. It has an effect on immune function, where it decreases the immunity. Hence, with excessive cortisol secretion, there can be immunosuppression along with it, and there will be increased gluconeogenesis and lipolysis and proteolysis also. Thus, cortisol has effect on carbohydrates, proteins, and also on the fat. So this is how cortisol actually acts. So coming to the Cushing syndrome, we are coming back to our original thing. How this can be classified, how hypoadrenocorticism can be classified. It can be grossly classified as ACTH dependent or non-ACTH dependent. So when you are talking about ACTH dependent, as we already knew this ACTH has been secreted by the anterior pituitary. So if the hypercorticism, that is the Cushing syndrome, is based on the ACTH, where it is ACTH dependent, it can be due to pituitary dependent bilateral adrenal hyperplasia, or because of any ectopic ACTH syndrome, or it can be iatrogenic also, where ACTH therapy, because of any external ACTH therapy patient is undergoing, then it can lead to hyperadrenocorticism or increased levels of cortisol. Then coming to non-ACTH dependent, again it can be iatrogenic, that is exogenous corticosteroid therapies. It can be because of any adrenal carcinoma, or it can be because of an adrenal adenoma again. Now coming to pseudo-Cushing syndrome, sometimes what happens is, there are certain factors, such as when patient is taking excessive alcohol for a chronic period of time, excessive alcohol, in case of obesity or major depressive illnesses. In those conditions, what happens, patients' clinical manifestations are very much similar to this Addison's disease. Very similar to the Cushing's syndrome. So but the major etiological factor is not that of Cushing syndromes. These manifestations, as they resemble Cushing syndrome, they are called as pseudo-Cushing syndrome. Okay. Now coming to various clinical features of this Cushing syndrome. Men are less affected when compared to women, that is, women are more commonly affected, and Cushing syndrome is usually seen between 3rd and 4th decades of life. And coming to various clinical features, the main clinical feature is unexplained weight gain. Patients will have hirsutism, that is unwanted hair, especially on the face, and in the areas which are not usually present with hair. Patient will present with backache, muscle weakness, psychiatric disturbances, and menstrual irregularities. This is because what happens whenever there is excessive of cortisol secretion, it has a negative effect on that is depressive effect on the gonadotrophins. So whenever there is decreased gonadotrophins release, that is, then it can lead to menstrual irregularity, it can lead to gynecomastia, it can lead to hirsutism, etc. Then other associated conditions are hypertension. Why hypertension? This is because whenever there is stimulation, that is ACTH is stimulating the adrenal gland, along with corticosteroids, there will be mineralocorticoid excess also. Little amount of it has a stimulating effect even for mineralocorticoids. So when mineralocorticoids are increased, obviously there will be hypertension, right? And plethora will be seen. We can see bruising, easy bruising, thin skin will be present, and striae, muscle weakness are other clinical manifestations. And the characteristic manifestations are moon face. Patients will have as I said, they have unexplained weight gain. They will also have obesity, especially centripetal distribution of fat, and they will have a characteristic appearance called lemon on toothpick appearance. Okay, and patients will have bulge face kind, that is called as moon face, and they also have present with buffalo hump. And there is something called as alcoholic pseudo-Cushing syndrome. This is because of alcohol excess, as we have just seen about it, right? And then coming to various other clinical symptoms of Cushing syndrome. When you're talking about generalized symptoms, patients usually have weight gain, they'll have slow wound healing, okay? Delayed wound healing can be seen in those cases. There will be increased risk of infections, fatigue, glucose intolerance. Other symptoms include headache, moon face, buffalo hump, muscular weakness, patient will have backache, skin is usually easily bruisable, thin, fragile, and we can see striae, purplish striae, especially on the abdomen region and on the nape of the neck. And we can see acne, excessive hairs can be seen, that is nothing but hirsutism. We can see striae on the abdomen, purplish striae, and psychologically they can have depression, anxiety, patients exhibit irritability in some cases, and also they have loss of emotional control, cognitive difficulty in these cases, especially when they are severe stress. Okay, one important thing is when patient is under severe stress, in those conditions what happens is adrenal gland to compete with that stress, it can release about 100%, that is double the time of cortisol can be released, that is 100% more cortisol can be released in cases of stress. Okay, so when more, especially in cases of excessive stress, they can have cognitive difficulties and decreased libido can be seen. Vascular, when it is coming to vascular manifestations, new or worsened high blood pressure. Increased risk of fractures can be seen when it comes to bone, because cortisol, especially in older age group, in menopausal women, what happens is this cortisol levels can lead to osteoporosis. In severe osteoporosis, as we know, they can lead to pathological fractures. And in reproductive system effect, when coming to reproductive system, in females they will have irregular menstrual periods, and in males they have erectile dysfunction. So these are various symptoms of Cushing syndrome. Now we have something called as cyclic Cushing syndrome. In the cyclic Cushing syndrome, there is actually episodic excessive secretion of cortisol. They will not have a constant elevated levels of cortisol, but at few periods of time or at certain episodes, we can see excessive secretion of cortisol in those cases. Now coming to oral manifestations. As these patients have various oral manifestations like fragile surface capillaries, especially on the face and skin. Patients usually, when we are talking about orofacial both symptoms, then in patient's face are usually ruddy in color. This actually can be mistaken as patient is hale and healthy, but that color is usually because of excessive cortisol. Patients can present with acne, hirsutism, and coming to dental, they have delayed dental skeletal growth and also delayed skeletal development. In these cases, as we already have seen, there will be immunosuppression because cortisol has a negative effect on immunity where there will be decreased immunity. In these cases, what happens? They will have immunosuppression. Because of this immunosuppression, many opportunistic infections can be seen, especially oral candidiasis and recurrent herpes labialis, herpes zoster. Gingival and periodontal diseases can be seen. Impaired wound healing, especially after an extraction or a gingival curettage. The patients usually will have impaired wound healing or delayed wound healing in these cases. And coming to the investigation, so how do we actually have to investigate that the patient is suffering from Cushing syndrome? Remember, there is no single test where we can actually say definitive test for cortisol excess. There are various tests which will actually, by help of doing different tests, we can come to a diagnosis that there is a cortisol excess along with various clinical symptoms. Urine-free cortisol is one among them. In this, what we do is we collect 24-hour urine and then check for cortisol levels in this case. In case of Cushing syndrome, there will be elevated urine cortisol and diurnal rhythm of plasma cortisol can be evaluated. We have something called as insulin tolerance test. Insulin tolerance test is a gold standard test, especially for ACTH axis, to check for the correlation of this ACTH. In insulin tolerance test, what happens is we give patient more amount of, we inject insulin and we check for hypoglycemic state after 0, 30 minutes, 45 minutes, 60 minutes and so on, and we have to check for hypoglycemia. But this test has a danger. It is potentially fatal because it can lead to severe hypoglycemia where sometimes patient can land up into crisis. In those cases, it is a potentially fatal also. Hence, this test has to be done under supervision or with the help of a physician to perform this test. And we have something called as dexamethasone suppression test, and this dexamethasone suppression test can be overnight dexamethasone suppression test, low dose dexamethasone suppression test, or high dose dexamethasone suppression test. What is this overnight dexamethasone suppression test? In overnight dexamethasone suppression test, what we do is we ask the patient for we give the patient dexamethasone in the previous night and ask the patient to fast all over the night and check it at 8 a.m. in the morning. So if at all the cortisol levels, we check for cortisol levels in plasma again. If at all the cortisol levels are still high, then it is considered to be Cushing syndrome. Similarly, we do low dose dexamethasone suppression test and high dose dexamethasone suppression test. Now coming to corticotropic releasing hormone test, it's also one of the investigations for Cushing syndrome, and we have inferior petrosal sinus sampling, plasma electrolytes, glucose, that is random blood glucose and fasting blood glucose, glycosylated hemoglobin, bone mineral density measurement will also be helpful in checking for Cushing syndrome. Now coming to the radiographic features. Normally, as we have discussed, there can be generalized osteoporosis and bone will have a peculiar granular bone pattern. Pathological fractures are common in them because of severe osteoporosis. Diffuse thinning and mottled appearance of skin can be seen. Premature eruption of teeth and partial loss of lamina dura can be seen around the teeth. Coming to the management, first, primary treatment. Primary treatment, always treat the underlying cause. If at all the Cushing syndrome is because of primary causes, that is, there is some problem with the adrenal gland, then go for surgery, which is nothing but transsphenoidal surgeries in case of pituitary hyperplasia, or adrenalectomy in case of adrenal gland tumors. Then we have agents that block adrenal steroidogenesis, that is, we have to block steroid production from the adrenaline, from the adrenal gland, and those include metirapone, ketoconazole and metotene. These are nothing but agents that can block adrenal steroidogenesis. We have something called as aminoglutamide. This will inhibit multiple enzymes and thus they can reduce the cortisol level circulating in the blood. Now coming to dental management. When these patients of Cushing syndrome come to us, then what we do? In those cases, what we have to do is antibiotic coverage is very important because as we have seen, they have immune suppression, severe immune suppression. In those cases, there can be supernumerary added infections can be seen and also delayed wound healing. So in those cases, if we suspect severe cortisol excess in those patients, then we have to go for antibiotic coverage, especially for dental alveolar infections, and assess the ability to withstand for stress, because dental treatments are full of stress. Patients will have severe anxiety. So in those cases, we have to evaluate whether patient can withstand the stress that while he or she is undergoing the dental treatment. If necessary, counseling for the patient, pre-medication either with anxiolytics with or oral and intramuscular glucocorticoids can also be given in those patients before we start a treatment. If at all the patient is on glucocorticoids already, then always double the dose before doing a procedure. This will help in preventing the body producing more amount of cortisols in in response to stress. As we are already providing exogenous glucocorticoids, that stress levels can be minimized and hence preventing further excessive production of cortisol in those patients. So pre-medication with oral or intramuscular glucocorticoids can be given. Now coming to Addison's disease. Addison's disease is nothing but hypoadrenocorticism. In this, what happens is there is decreased secretion of cortisol within the blood. Okay, or there is decreased cortisol level within the blood. In this, it is also called as adrenal insufficiency or hypoadrenocorticism or glucocorticoid deficiency. It can be due to loss of pituitary function where ACTH is not produced properly. When ACTH is not produced properly, this ACTH cannot further stimulate the adrenal gland. So the cortisol levels can be lowered there. And autoimmune destruction. In case of autoimmune destruction, especially in case of Hashimoto's thyroiditis, etc., what happens? These autoantibodies are produced against the adrenal gland itself, causing mass destruction of the adrenal gland. So here also there will be decreased cortisol secretion. Infiltration of the adrenal gland. If the adrenal gland has been infiltrated because of any tumor or where there will be actually the production of cortisol is being impaired, in those cases also there will be decreased cortisol secretion. Rarely sometimes what happens, there can be amyloidosis, there can be any metastatic carcinoma, there can be lymphoma, hemochromatosis, intraadrenal hemorrhage, which is nothing but Waterhouse-Friderichsen syndrome. Okay, in these cases also there will be decreased cortisol secretion. Now coming to adrenal insufficiency, in this adrenal insufficiency can be seen in cases of HIV/AIDS, in case of tuberculosis, severe fungal infections or cytomegalovirus infections. Now coming to the clinical features. So how do these Addison syndrome manifestations can be seen? They usually present with loss of appetite. Patients will have unexplained weight loss. There will be low energy, hypotension, cardiovascular collapse and death can be seen in severe cases, and hyperpigmentation can also be seen. In case of acute presentation can be by circulatory shock with severe hypotension, hyponatremia, hyperkalemia and hypoglycemia. They can also have other constitutional symptoms such as nausea, vomiting, muscle cramps, fever, diarrhea and constipation. Coming to chronic presentation, they will usually present with pigmentation. This pigmentation is because whenever ACTH stimulation is done, along with ACTH what happens is melanocyte stimulating hormone, that is MSH, is also produced at the same time. Okay, because the gene which is present, which is actually coding for both of them, is similar in few arms. So whenever there is stimulation of ACTH, what happens? There will be concomitant stimulation of MSH also, which will stimulate melanocytes to produce more amount of melanin. Hence, there will be pigmentation in these cases, which is a pathognomic feature of Addison's disease. Now, coming to postural hypertension, they will also have in the chronic presentation, and vitiligo can also be seen. When coming to other oral manifestations, usually they have unusual skin pigmentation, especially perioral region around the mouth. They have a tan complexion. Okay, tan-like complexion can be seen in these cases. Patients usually have intensified freckles and moles. There will be increased pigmentation at mucocutaneous junction and even in the mucosal surfaces, especially the buccal mucosa and gingiva. Oral pigmentation, we can see irregular spots which are pale brown, grey or black in color. So coming to the diagnosis of Addison's disease, this is because of lack of glandular response. Okay, to assess, hence to diagnose them, we have to assess for glucocorticoids and mineralocorticoids. For this, we have to do something called as short ACTH stimulation test. Blood glucose will also be helpful. Insulin tolerance test is also helpful in these cases, and we have something called as short cosentropic test, which will also be helpful for diagnosing Addison's disease. So how do we manage the administration of exogenous corticosteroids? Because already patients' cortisol levels are low, so administration of corticosteroids will be the mainstay, and mineralocorticoid replacement also has to be done along with this, because patient already is presenting with hypotension, hyponatremia, hyperkalemia, where the normal body blood pressure is not maintained. Hence mineralocorticoid replacement is also very useful in these cases. Now coming to the dental management, similarly antibiotic coverage is important. Always assess for ability to withstand stress, pre-medication as we have discussed to maintain the stress levels. In case of any acute adrenal crisis, okay, in acute adrenal crisis, always think about intramuscular or intravenous hydrocortisone. So this is all about the adrenal gland, both hypercorticism and hypocorticism, and we have discussed about the clinical manifestations and the radiological features, and also we have discussed about the dental management. So this covers about both Addison's disease and Cushing syndrome. Thank you.